Okay, guys, let's get started. So we're going to try and talk about the ulnar nerve today, and just go from A to Z, basically anatomy, and then when things go wrong with the ulnar nerve, what to do about it, and then the nerve compression syndromes of the ulnar nerve. And there's a separate tutorial for the medial nerve and the radial nerve, and that sort of pretty much gives you a pretty quick exposure to a big chunk of hand problems, hand pathology. So I don't know how well this projects, but basically, as you can see, there's the brachial plexus. I think it's very important to return to the right side. It's very important to appreciate this M here. Okay, it's not brilliantly drawn over here, but this M, in between the posterior cord and this part of the plexus runs the artery. And this M is a very critical aspect of the surgical dissection. Also, just understanding the brachial plexus, especially when you have to come and describe it in a clinical scenario in an exam, because this is where everybody gets quite confused. So remember that this is the sort of level of the clavicle roundabout here. So we talk about the ulnar nerve, which is here. So the ulnar nerve comes off the medial cord. And the medial cord really just gives off the ulnar nerve, but it also gives off this very big branch to the median nerve. It's the medial limb of the median nerve. And then the lateral limb of the median nerve, base of the median nerve, there's the ulnar nerve. And then there are two small branches more proximally, which you'll often see, especially when you get called into the theatre by the vascular surgeons who are doing a brachial artery, and I'll say to you, there's a big nerve injury, and it often can be the medial cutaneous nerve of the arm or the medial cutaneous nerve of the forearm. Those two branches there. So it's quite a confusing nerve, and also this will come up again just now when we talk about the cubital tunnel exposure and how it's easy to get into trouble with the medial cutaneous nerve. So working backwards, the ulnar nerve comes off the medial cord, and as you can see here, the medial cord is pretty much made up of only C8 T1 fibers. The C8 and T1 fibers form that's the upper trunk, the middle trunk, and the lower trunk. It's not very well drawn this, but the lower trunk gives off a posterior division, which goes off to the posterior cord, and the anterior division continues as the medial cord. Okay. All the trunk splits into anterior, posterior, anterior, posterior, anterior, posterior. It's not brilliantly drawn. That should be a bit more downstream than that. Okay. So just some more anatomy. You can see there's the M again. So when you're doing the delta pectoral approach and you've been called into the theatre and the guys are struggling and you're trying to work out what nerves damage, or you're doing the exposure, you need to find the nerves. You need to identify that M, and it can be difficult because the artery wraps around the artery the M. It's not in 2 dimensions, in 3 dimensions like that. So there's the M. And that's the lateral cord giving off the musculocutaneous nerve. There's the median nerve, and then there's the ulnar nerve running down here, running down the back of the arm, the medial aspect of the arm. Very importantly, it gives absolutely no branches in the upper arm. The other thing about the median nerve, the ulnar nerve, which is quite strange, not really sure. I haven't actually read any articles about why it did that. You know, developmental progression through the mammalian line, obviously mammals to primates, of which we just a primate, and there's something to do with being quadrupedal and then rotating our arms and arboreal and brachiating and all that sort of stuff. But it doesn't really make absolute sense why this nerve, the ulnar nerve, should go from the anterior compartment, it's anterior, then it dives posterior, runs the whole way posterior. Okay, then it comes anterior, so it runs anterior, then it dives posterior through the medial intermuscular septum, runs around the back of the medial epicondyle, and then comes into the anterior compartment again. And that traverse from anterior to posterior back to anterior is what actually gives the ulnar nerve all its trouble. If it just went freaking straight next to the medial nerve and break the artery, it'd be fine. Okay, we'll come back to the anatomy of the of what it goes through a bit later. And then it goes into the forearm, and it supplies in the forearm. It runs through the two heads of FCU, and then runs underneath FCU all the way into the wrist to Guyon's canal, and it supplies only 3 muscles in the forearm: FCU, flexor carpi ulnaris, flexor digitorum profundus, FDP, to little and ring. Disregard index and middle. Little and ring. Okay, those are the only 3 muscles that it supplies in the forearm. And then this is just a close-up of the anatomy as it goes through the 2 heads of FCU, but we'll come back to that a bit later. And then it goes into the hand, and in the hand it supplies, remember the medial nerve supplies all the good sensation of the hand, but a couple of muscles. The ulnar nerve supplies very little sensation, but a lot of important muscles. Every time you see someone painting, writing, carving, playing the piano, doing anything involving dexterity, you actually have to just lower the ulnar nerve. It's an incredible nerve for both strength. Without the ulnar nerve, you've got no strength, and without the ulnar nerve, you've got no dexterity whatsoever. All those fine movements of the hand are powered by the ulnar nerve. So, my glasses on here, but the ulnar nerve comes in there, there it goes there. It goes just on there's the hook of the hammer through Guyon's canal, gives off the motor branch, and then continues as this trunk here. There's a small branch to the hypothenar muscles. This trunk here, then splits, that's the sensory trunk, and it splits into the ulnar digital nerve of the little finger, and then the common digital nerve to the 4th workspace, giving off those 2. So it supplies the whole of the little finger and the ulnar half of the ring finger. And the muscles supplied in the hand are these ones here: the hypothenars, all the interossei, the adductor pollicis, half of the flexor digitorum brevis, and the medial 2 lumbricals. Okay, I'll come on to that a bit later when we talk about the pathology of the loss in the hand. Okay, so these are the tests if someone's missing an ulnar nerve. We just talked about what nerve, so obviously you want to test the FCU. That's quite an easy one to test. You ask your patient to flex an ulnar deviation and you palpate the FCU. It's a very strongest forearm flexor tendon by far. FDP little is quite an easy one to test. You ask your patient to bend and you compare to the other side. Don't bother with the ring finger. The ring finger is too variable about what supplies it, so don't even bother with the ring finger. And then ADQ, I find quite tricky to test. It's easy to test, but it's difficult to measure its strength, ADQ. But the first dorsal osseous is very easy to measure its strength. If you take your average patient, even an 80-year-old woman, and they ask them to abduct the index finger, with your single finger on their PRP joint, you should not be able to break that first dorsal osseous. If you can break it, it's weak. Okay, if you can push it down, it's weak. Doesn't matter if it's a little granny or it's a freaking butch rugby player, it makes no difference. It's a strong muscle in almost everybody. But compare it to the other sides. The first dorsal osseous is an important one and a sensitive one to examine. Then obviously you can test pad and dab, abduction and adduction, overlapping of the fingers and all those things. But to be honest, it's fiddly and it's unnecessary. Okay, you test the first dorsal, and then we look at Frohman sign and Gene sign. So this is Frohman sign. There's a very subtle difference between the 2, but you see that's a classic Frohman sign. Person doesn't have an adductor. They've got a weak adductor, so they have to increase the lever, the force mechanism of the FPL. So they use the FPL and the FBB harder and harder with their medial nerve innervated, half of FB. So they end up hyperflexing the thumb. That's the main reason. Okay, to achieve the same degree of strength pinch, they have to flex the thumb using the FPL, which is the problem with the Frohman sign is that it shortens the working length of the thumb. Remember, your thumb wants to contact against the side of the index finger, and if it's too short, it misses the index finger. And then this is Gene sign here, where you get a similar posture to the IP joint, but you get hyperextension of the MP joint. So it collapses into hyperextension. That's Gene sign, and that's due to the fact that Normally, half of your FPB is supplied by the ulnar nerve and half medial nerve, but if the whole nerve is supplied by the ulnar nerve, then there's nothing to flex the NP joint, and it goes into G sign. And then an uncommon sign, or we don't really notice it that often, is Wartenberg sign, which is the abducted little finger. And that's due to the fact that you've got the extensor digit minimi working unopposed. There's nothing to pull it in. So the extensor digit minimi pulls it out. Okay, there's no interossei to pull it back in. Wartenberg sign. And that can be quite distressing to the patient because they got this finger that sticks out every time they try and do anything, put their hand in their pocket, it keeps catching. And it can be quite substantial, really stick out like that one. That's quite a bad one. Okay, so that's the anatomy of the ulnar nerve. There's not really much more you need to know. That's basically the quick little take-home message. Just commit that to memory. It mustn't be, when you come to hands, you can't be sweating to get that out of you. That must just be known. Okay, that's actually second year, third year, fourth year stuff. Med student, not registrar. Okay, so that's just got to be known. Commit to memory. Okay, then the entrapment neuropathies of the ulnar nerve. Well, if you just once again follow the ulnar nerve, there's nothing up at the top there. Then the first thing it does, it goes from the anterior compartment to the posterior compartment through the medial intermuscular septum. And that little arcade that it goes to is called the arcade of Struthers. It sits about 8 to 10 centimeters above the medial epicondyle. I hardly ever see it as an issue, but obviously if you transpose the ulnar nerve, so the ulnar nerve goes from anterior to posterior, and then down the line goes back to anterior. If you then put it forward, it's going quickly from anterior to posterior and then back to anterior again. It's going to kick. So you've got to go and release the medial intermuscular septum all the way up to the arcade of Struthers, which is about 8 centimeters, which is about the breadth of your four digits. Okay. And then you've also got cubital tunnel and Guyon's canal. Those are the three entrapment sites. Okay. Cubital tunnel, confusing subject. I've got another presentation on cubital tunnel. So I'll just run through this now. But basically, it can be from the bulging head of the medial head of triceps. There can be an abnormal muscle called enchyneus epitrochlearis. You guys know, obviously, from your anatomy, you know you get a lateral enchyneus muscle. Well, from an evolutionary point of view, we also got a medial enchyneus called, but it's vestigial, so it's disappeared, leaving the Osborne's fascia behind. Okay, and but some people still have it. Occasionally open up and to find that there's a muscle right there, which is called enchyneus epitrochlearis. So it's the medial enchyneus, not the lateral enchyneus. Then you get Osborne's ligament and Osborne's fascia, confusing difference. So I'll get on to where I understand it, but no one really actually agrees on what's what there, but I'll tell you the way to remember the way I do. Then remember, you can also get patients that have got long-standing cubitus valgus from elbow trauma, specifically pediatric elbow trauma, and they get cubitus valgus, and then down the line, the nerve is running around a sharp corner in valgus, and then they get a tardy ulnar nerve palsy. And then any pathology in the medial joint line where the nerve is running, such as ganglions, OA, or osteophytes, or basically those. Okay, so this is a couple of different drawings, and I think they all say the same thing, but they all actually tell you different messages. Here you can see this drawing. There's the medial epicondyle. There's the olecranon. There's a band that goes from the olecranon to medial epicondyle, and then there's the two heads of FCU have got a fascia overlying them. And what you call all these things is variable. I call this Osborne's ligament, and then I call that fascia Osborne's fascia. But you can see that's Osborne's ligament. Here it's called, that's called Osborne's fascia. That's Osborne's ligament, the same thing. One's called the ligament fascia, and the same thing I can't read that right, it's too small. But that's where enchyneus epitrochlearis used to be, and that's now the remnant of that ponderosis. I call that the ligament, that sharp band, and then it becomes Osborne's fascia as it covers the two heads of FCU. That can be an area of compression. So remember now, we've talked about the arcadis struthers, where it goes through the septum from anterior to posterior. Now we're talking about cubital tunnel, which we'll talk about the management thereof in a second. And then there's still Guyon's canal down the stream. So this is how you classify cubital tunnel syndrome. It's the McGowan classification. There is a modified McGowan, but let's just stick with this one for your understanding and simplicity. Number one, intermittent symptoms and no signs. The patient will tell you they get like pins and needles at night, in the morning, when they do this, when they do that, when they brush their teeth, when they're on the phone, when they're bending their elbow, whatever. They get, when they're sitting, resting their arm on a surface, they get pins and needles, but there's nothing to find. Okay, that's a McGowan 1. Very difficult group because they might not be cubital tunnel at all. Once they've got permanent symptoms, in other words, objective symptoms, you examine them, they've got definite sensory deficit and they've got definite motor deficit. So when I say motor deficit, I'm talking about the FTP to the little finger and the weakness of the FTR, the first dorsal endosseus. Those are the two you're looking at. Front one side, all that stuff's difficult in these early McGowans. But if they get mild motor and sensory deficit, then they've got a McGowan 2. Once they get dense motor and sensory loss, it's a McGowan 3. Yes?
Is this specifically for cubital tunnel? So if you've localized something a bit more proximal or perhaps a bit more distal, you can't use this. So
this is for cubital tunnel. This is purely for cubital tunnel. So how do you assess them? You want to do a canal test to try and work out where the sensitivity is. You're trying to palpate the nerve. Is it thickened? Is there some mass lesion in it? Is it subluxing? Very important. We'll come into the clinical management in a second. Subluxing. Very important. You extend the elbow, palpate the nerve, bend, and make sure the nerve isn't subluxing over the medial epicondyle. You can do the elbow flexion test, EFT, 1 minute time with the hand on the shoulder, and the patient says that after 45, 50 seconds they're starting to get tingling, then it's due to, then it's almost definitely cubital tunnel syndrome, and that's the problem. They're getting it when they flex the elbow, dynamic problem. And then obviously a thorough motor and sensory examination. Specifically looking for other reasons that they might have these symptoms. So I think I'll get onto in a second. So differential diagnosis, cervical disc, thoracic outlet syndrome, syrinx, syringomyelia, and other brachial plexus pathology, schwannomas, Pancoast tumors, neurofibromas, malignant lesions, lots of pathology there. But remember, ulnar nerve only supplies sensation to the hand. It never supplies the forearm. So once the forearm starts to get involved, the patient's adamant. But the problem is, if you ask patients, they say, where's it numb? They say, here. So they'll show you there. But if you examine them and there's nothing there, then it's probably the cubital tunnel. But if it's something in the forearm, it's definitely not the ulnar nerve. It's up here somewhere. Because that means it's proximal, it's at the level of the medial cord, or proximal. So then you've got to look for a cervical disc, or thoracic outlet syndrome, the rare type, the neurogenic, true neurogenic type. Syringomyelia can cause marked motor, ulnar nerve type motor, intrinsic wasting and weakness, but with very little sensory deficit, but it can also have sensory deficit. And then brachial plexus pathology. So if it's atypical, you need to look a bit harder to try and find the cause. Remember, the medial cord is the deepest one, closest to the apex of the lung. It's coming from CAT1. It's closest to the first rib. It's closest to all the, if there's going to be problems coming up from below, it's going to take out CAT1, the lower trunk, the ulnar nerve fibers. Okay, so treatment, I think I'll come back to this in a second, but just remember, in essence, you've got two options: releasing in situ or transposition, anterior transposition. So you move it forward in front of the medial epicondyle. Those are your two different treatment groups. But I've got a whole talk on that. Oh, here it is here. Ulnar nerve at the elbow. So I think the first question. And I'm just going to put it out there just to get you guys thinking, especially when you become independent consultants at some stage. First question you have to actually ask, is cubital tunnel cubital tunnel, because there's no doubt there's a lot of patients who present with these vague pins and needle symptoms, and it's hard to prove that it's cubital tunnel. I'll get onto the nerve conduction studies in a second. It's hard to disprove it, and often end up getting operated on. Some of them get better because they got better anyway, and some don't get better because they weren't cubital tunnel in the first place. So it can be a difficult diagnosis to make. It's surprisingly difficult, cubital tunnel syndrome, unless it's obvious. But it's amazing how often it's not obvious. So just remember, you get things like Parsons-Turner syndrome or brachial neuritis. They can present with very weird upper limb sensory and motor deficits. There are other neuritises, even the ulnar nerve can be a mononeuritis, diabetes, from thyroid, from many other autoimmune conditions. If you get a mononeuritis, it's not a cubital tunnel, it's not a compression neuropathy, it's an intrinsic nerve pathology. And then CAT1 radiculopathy, thoracic outlet, and many other. And once again, we also don't even know what the natural history of cubital tunnel actually is. If you just leave cubital tunnel alone, a lot of registrars get cubital tunnel, especially when they suddenly arrive in hands. Firstly, they're suddenly aware of it. And secondly, you spend all day, hours operating like this with your elbow resting, and a lot of people complain of cubital tunnel. I've coached a lot of ortho registrars and plastic registrars through cubital tunnel syndrome, and fast forward 5-10 years, it's disappeared. They got over it, or they forgot about it, or went away, or they learned to adapt to maybe the way they're operating. I don't actually know what happened to them, but they never had operation. Conservative management, avoid flexion. We'll come back to this. And nice splints. Now, avoiding flexion is obviously way more difficult than it's easy to say, avoid flexion. But I mean, basically, fundamentally, we do everything with our hands in flexion. You're sitting on the phone, you're talking in flexion. You're working on a computer, you're working in flexion. You're sitting in a chair, you're working in flexion. Often when you're sleeping, we all tend to sleep in a slightly flexed elbow position. So it's very difficult to avoid flexion, but it is critically important. This is the fundamental problem with cubital tunnel syndrome. It's a flexion problem. Okay, and then obviously avoid extrinsic pressure. At least a couple of times a year, I see patients who come back from these big international flights, popped a sleeping tablet, and they've woken up with a full-blown ulnar palsy because they've fallen asleep on their armrest. So you've got to avoid extrinsic pressure when you're working, when you're operating, etc. NSAIDs, not really. Neural stretching, everybody, the physios love that. It's interesting, neural stretching. If you want to ask me what I think cubital tunnel actually is, in the vast majority of patients, cubital tunnel is an inability to neural stretch. So when you're young and agile, etc., and a-traumatized, your elbows, your nerve can stretch. It's an elastic structure. If I took it, if I harvested a fresh cadaver's ulnar nerve, I could probably stretch it, I don't know, 5-10%. I would imagine. I don't know, never tried it, but I would imagine. And every time you bend your elbow, I think that nerve stretches. But after years of hitting your funny bone, extrinsic pressure you don't even know, subconscious, I think you cause intraneural fibrosis of that nerve, and suddenly it is not a pliable nerve anymore. It can't stretch. So if it has to stretch, in other words, you bend your elbow, and it can't elongate, then what's it going to do? It has to it's going to try and transpose itself. It's going to try and jump across the gap. It's going to bowstring. But it can't because it's held by all those structures, and that's what causes cubital tunnel. And basically, nerves can stretch. Nerves can lengthen. Look at Maritz and all these work with those leg lengthening devices. That nerve doesn't get long and thin. It actually grows. If you lengthen a leg 8 centimeters, the nerve grows 8 centimeters. It doesn't become 8 centimeters longer and thinner. Okay, otherwise it wouldn't work. So nerves can lengthen if you just get them. So I think this neural stretching is probably not a bad idea. But it's hard to, the physios love it. Not the chiros, but the fancy physios called. The bios love that one, neural stretching. Cortisone injection, definitely not. Don't stick cortisone anywhere near the median nerve, the ulnar nerve in the elbow. It's a very tight space, and you will damage the ulnar nerve, and it's an unforgiving nerve. So if you look at one or two studies, there are some studies that show 50% of all patients with cubital tunnel syndrome will improve, so leave them alone. And there's this extensive work by Lee Dallon, and you know, it doesn't help us really to know these stats, but it shows that some of them recover. Okay. Fine, we'll leave it there. But obviously we are surgeons, we want to operate, we do operate, that make things better. So when would I operate on cubital tunnel? Failed conservative management or any worsening symptomatology. So if a patient is failing conservative management, worsening symptomatology, or objective McGowan 2 or 3, that's a given. Then they have to be operated on because you haven't got time to waste. And there's the McGowan classification again. Okay. Surgical options, again, coming back to that. So the options are to release it in situ, just leave it in its position, which you can do open, or some people do endoscopic, or release and transpose the nerve. And the way to transpose the nerve is either subcutaneously, intramuscularly, or submuscularly. Obviously, very different operations, all of them. And I've just put there because the Yanks like the medial epicondylectomy. They actually just take the medial epicondyle off, just proximal to where the medial collateral ligament takes origin, attaches. So you just take the medial epicondyle off, and now all of a sudden, every time they bend, the nerve can jump over this missing medial epicondyle. So it's a form of micro transposition, if you want. Okay, or minimal transposition, not micro. Okay, so yeah, I think I personally have gone full evolution on this. I learned and only ever did some muscular transposition every time it was necessary. And now I would say 99% of the time I do a subcutaneous transposition. And the person who changed my mind on this is this guy here, Robbie Kempson. I don't know if any of you even remember who he was in the World Cup, the original World Cup rugby team. And he's a huge, big forward. Was he a hooker? Prop, eh? He played prop, which for those who don't know, it involved a lot of binding, hard binding around the back and neck of the other guys. And he came to see me for a second opinion. He had bad cubital tunnel just before the World Cup. And I said to him, and he was going to have a subcutaneous transposition. I said, well, you're nuts. I mean, you know, the nerve's going to be completely exposed. Every time you get hit, every time you take a tackle, you're crazy, you're nuts. You've got to have a submuscular, but if I have a submuscular, I won't be able to play. I said, well, then you must just take your chances and not have it, and then play the thing, and then straight off the World Cup have the race. Anyway, he went back to the original surgeon, thank God. I would have popped him up fully. And he had a subcutaneous transposition, and I saw him about 5 to 10 years later. And I asked him, how's it going? I told him my whole story. I was worried about him. He said, no, it's perfect. It's 100%. Never worried me. He played another 5 years of rugby. Never worried me. I thought, yes, well, if Robbie Kempson can have a subcutaneous, then anybody can have it. And that's what the literature actually showed at the same time. You don't need to do submuscular unless you have to do submuscular, which I'll get onto in a second. So this is what I basically do. This is my sort of way of thinking about it. So I do in situ decompression for McGowan 1 and now McGowan 2, because that's what the literature says. It shows no difference in McGowan 1 or 2 when you do a in situ or a transposition. All McGowans 1 or 2, and especially if I find obvious pathology. Now that sounds weird. If I find the nerve to be compressed, then now I'm releasing it in situ, and I've sorted the problem out. There's the nerve. It's trying to get through a very tight Osborne's ligament. I release the Osborne's ligament. I've sorted the problem out. But most of the time, as you guys know, if you've been in hands, there's very little pathology. You find nothing. The nerve looks pristine because it's a dynamic problem. You can't see it. Very seldom is there a problem in a static position. It's only in dynamic. So I mostly do in situ decompression. When do I do subcutaneous transposition? In the majority of cases, any McGowan 3, any case where the nerve wants to sublux or anteriorize itself. So what I do is I do in situ decompression, and intraoperatively, flex the elbow. And if that nerve starts jumping over the medial epicondyle or wanting to ride up and looks like it's going to jump over a couple of weeks later, I just do a transposition. Okay, so that's why I start off with every intention of doing an in situ decompression, because the literature says it makes no difference, least in situ or transpose. But often it wants a sublux, and I'm not prepared to take a chance. I just then transpose it. Okay, but now I do subcutaneous transposition. Any cubital tunnel pathology, you can't leave it there. There's a problem in the cubital tunnel. You can't leave it in the cubital tunnel. You must transpose it. Any cubitus valgus, it's going around a bad course, it needs to take a shortcut. So you transpose it. And as I say, if I find no pathology, if it's a pristine looking nerve, I'll have a low threshold for just doing a transposition, because it probably tells me that it's a dynamic problem. And when would I use submuscular? If I have to revise the subcutaneous, or in very, very double, very thin patients. Used to be for very thin, now it's double, very thin. Okay, and what will happen is you take these very thin patients. I'm not going to point to anybody in this room, but if you take someone, and I've done it before, where I've done a subcutaneous transposition, I've closed the skin, and as I'm looking at the skin, I can actually see the nerve through the skin. You actually see it sitting there, you think, well, that's just ridiculous, I can't leave it there. So then I'll open up and lift up the muscle and put it submuscular. That's just my way of doing it, doesn't necessarily mean it's right. Okay, so this is just explaining once again what I'm talking about. It's a dynamic problem, in contrast to carpal tunnel syndrome, which is a static problem. Carpal tunnel is always there, the nerve being squashed all the time. This only occurs when the nerve is hyperflexing. You can see how it wants to go around that tight corner, causing the compression, because it wants to transpose, but it's getting caught in that sort of tight apex between the cubital tunnel floor and the roof of the cubital tunnel. It's getting forced into that gap there. And when you operate, you put it back in extension, you can't see anything. Obviously, you can't see anything. It's a dynamic problem. Okay. Okay. And once again, I know there is a place here where I talk about it, but this is why I don't do nerve conduction studies on these patients, because most of the time, if they will find a problem on the nerve conduction studies, well, it was freaking obvious clinically, you didn't even need it. And if they don't find a problem, it doesn't help you, because they are doing it in a static scenario. They're not doing it in a dynamic scenario. They never ever get the patient to sit for 10 minutes in a bent elbow and then test it. So that's why it often comes out normal. So it doesn't help you. The literature agrees there's no difference in outcome, simple decompression versus transposition. Several prospective randomized studies, no difference, and lower complication rates in simple decompression or in situ decompression. Okay, so I think that's probably the most important thing. Once you start transposing the nerve, the complication rates start going up exponentially. Okay, it's a good operation, starting point for everything, but test the subluxation intraoperatively and decide. And unfortunately, it's a subjective test. I look at it, I say, well, I think it's going to sublux. Or the other person says, no, it will never sublux. There's no way of quantifying that. And then just remember, once you start dissecting the two transpositions, you start running into these important nerves, which is the medial antebrachial medial cutaneous nerve of the forearm. It's got a slightly distal branch and a slightly proximal branch. 1 centimeter proximal and 1 or 2 centimeters distal to the medial epicondyle. When you start doing transpositions, you start taking out those nerves, and the patients then end up with neuromas and abnormal sensation. They're not happy. So here's a couple of cases. You can see obvious compression of the nerve there, sort of with that typical band, and that's right there. There's the two heads of FTU, and that's right there at Osborne's ligament, what I call Osborne's ligament. It's showing the same thing. Eh? There's the medial cutaneous nerve. It continues to damage it. There's another medial cutaneous nerve branch. Those are those two branches there. And then there's the squash nerve as well. So the Osborne's ligament. There's another. I think this could be an intraneural which I know that I remember correctly. No, she's a lady that looks like a very hairy dog. I don't remember what that was. So why do I do so many subcutaneous transfusions? In the vast majority, the nerve is trying to sublux. I think simple decompression is a sub-minimal transposition. When you do it inside to decompression, and they bend the elbow, the nerve rises up, but it doesn't jump over. So it's giving itself room to move without getting pinched. If you do a medial epicondylectomy, it's a minimal transposition. If you do a full transposition, then you've done the transposition. That's how I think inside to works. It allows the nerve just to move it a few millimeters, which is enough. So as I say, it's a dynamic problem. Nerve conduction studies are often helpful. I don't use them at all. It's a complete waste of time in my hands. Okay. Anterior subcutaneous transposition, thorough dissection, preserve all the branches, avoid devascularizing the nerve, remove the intermuscular septum, obviously because otherwise it goes anterior, posterior, anterior again immediately. You've got to remove the intermuscular septum, otherwise you kink the nerve. You want to make sure it stays there where you put it as far midline as you can. If it's too close to the medial epicondyle, every time they bump the arm, they'll feel symptoms. Okay. So this is basically, the sort of the flow from simple decompression to anterior subcutaneous to anterior submuscular. Obviously, the further down the big operation, prolonged recovery, and elbow complaints after the operation. So definitely aim for in situ release. I think it's an operation you must be able to do and get waxed. Zero complication rate for that operation. Okay. I won't talk about that. Then this is Guyon's canal. Much less common. I do see a couple of the cases. The most common by far that we see are these extrinsic compressions. So the extrinsic compression, after the August, every year I see at least 2 or 3 patients with cycling palsy. Also, when these guys go overseas and they do those long Alp races or cycling across to wherever, from wherever to wherever, they come back with an ulnar palsy. Paddlers paddling down the Orange River. They hold the pedals in a bad way, they catch the ulnar nerve. So those are the 2 groups that I see. And remember, there is a classification zone 1, 2, 3. I wouldn't fuss too much about that. But zone 1 is proximal, where it takes up both motor and sensory. 2 is motor, if I remember correctly, and 3 is sensory only. I wouldn't bother with that. Okay. But the vast majority you see are type 2, which is motor only. Any questions about cubital tunnel, Guyon's canal? So the other thing with Guyon's canal is you often do see the patients with ganglion coming from the piezo-tricutal joint going into the Guyon's canal. Remember, if they've got Guyon's canal involvement, the FTP to the little finger is intact and the dorsal sensory branch of the ulnar is intact. So that's how you differentiate there from there. Obviously the tunnel and the symptoms and what you're looking for. But the 2 big differentiation clinical features are FTP to little, that should be normal, and the dorsal sensory branch is normal, because that comes off well proximal. That comes off, that only joins the ulnar nerve here. So obviously any problem there won't affect the dorsal sensory branch. Okay, that's very important. That's pass-fail in the exam. Okay, tendon transfers. Whenever you guys must commit to memory for the exam, when you're seeing a patient with an ulnar palsy, only 3 things you have to discuss. I know there are 4 there, but there are only 3 things you have to discuss as you've been growing on. Every patient with an ulnar nerve, you need to look at their clawing, their grip, their pinch. Claw, grip, pinch. Claw, grip, pinch. Just remember that. Commit that to memory. Okay. Yes, they do have unbalanced flexion. So what happens with them is that because they don't have intrinsics, just bear with me for 2 seconds, but your intrinsics on the flexion side bend the MP joints, and then the extrinsics take over and commit to flexion. If you don't have intrinsics, you have to roll your fingers up. Okay, that's a problem for some patients. They don't like to roll their fingers up. They can't grip things. That's called unbalanced flexion. They can't initiate and then wrap around. Remember, on the extensor side, it's the opposite. The intrinsics work these joints, and the extrinsics work your MP joints. Okay, so flexor side, intrinsics, extrinsics, extensor side, extrinsics, intrinsics. Hope that makes sense. Okay, but anyway, unbalanced flexion, they don't like to curl their hands up. So you see them, but there's not a whole lot you can do about that. And it sort of comes under the clawing and the weak grip later down the line. So that's why I don't discuss it as a separate thing. So those are the three you need to commit to memory. Claw, grip, pinch. So there's the claw, the typical ulnar nerve claw. Remember that they've lost all the intrinsics except those two lumbricals, index and middle. So they can keep them out of a claw position, those two lumbricals. It's not much, but it's enough. But they go into this marked claw position because they've got no intrinsics. And if you block the MP joints in flexion, they can now extend the interphalangeal joints using the extrinsics. Because normally the extrinsics extend your MP joints. If you don't let them extend the MP joints, then they can extend the IP joints. That's called Bouvier's test. Bouvier's maneuver, Bouvier's test. And that's critical to understanding the reconstruction of the claw hand. Understanding Bouvier's test. What's the problem with the claw? Doesn't look nice. That's not the problem. Irrelevant to what it looks like. The problem with the claw is that if it claws too much, then that flexed fingers are in your way. You try and put your hand around a cylindrical object, you can't get your hand there because the clawed fingers are in your way. So you only operate on a claw when it's bad. You don't operate on a claw because it's there. Okay, claw is difficult to fix. And how do we fix it? We recreate Bouvier's test. So this is called a knuckle duster splint. That is a permanent Bouvier's test. The MP joints are blocked in flexion. They can't be extended. So the extrinsics take over and can extend the fingers. And they can live like that for weeks, months, even years with their knuckle duster splint, it's called. Okay, but they're not going to live like that forever. And eventually, at some stage, you have to put a knuckle duster splint into their hand. What I mean by that, you have to put it in a flexion deformity at the MP joint. And if you just look at your hand, well, how do you do that? Well, it's easy. It's not, but it's easy. You can either just pinch the skin, the dermodesis, or you can do a fasciodesis, or you can do a tenodesis, or you can do a capsulodesis. You've got to do some sort of desis to keep the MP joint in flexion. Okay. Obviously, a dermodesis is going to stretch out, a fasciodesis is going to stretch out, a capsulodesis is going to stretch out. So all you've really got is a tenodesis. But it's easier said than done. So these are the different ones. This is the most common. Okay, so there's the Zancoli capsulodesis. Zancoli describes the capsulodesis. You take the volar plate and volar capsule and just tie it down to the bone to create the flexion deformity. And then this is the Zancoli, the most common one we use. Zancoli, what does that called? Okay. Zancoli, this is the Zancoli lasso. Okay, so you take the FDS and you wind it around a little bit of the whole of the A1 and a little bit of the A2 pulley. And you basically put the FDS around it and pull it down. Now it can't go back because you're pulling down on the A2 pulley. You're pulling in a flexion deformity. That's Zancoli's lasso. And that's using FDS. And that's the most commonly performed anti-claw operation in the world. And it's the least commonly performed at Kuzinski Hospital. And the reason for that is that the world operates on ulnar palsy for leprosy. We operate on ulnar palsy for trauma. And what do our patients get when they have a trauma? They take a panga or a piece of glass and they cut their ulnar nerve. And they also cut the FDSs, almost always. So we don't have spare FDSs to create the Zencoli. And that's why it's so difficult to reconstruct it, because it's easy to do Zencoli. All these other ones are difficult, as you can see from these complex drawings. Okay, but basically they're all trying to do the same thing. They're just trying to use different graft material to pull the MP joint down. Okay, and I don't think you really have to know much about it. Okay, let's see what this graft is. I'm going to talk about this one, and we'll come back to this one in a second. Okay, so that's the clawing operation. Just to understand that you have to create a flexion deformity. The Zencoli lasso is what we use mostly, if we can, but often we can't, and then we'll probably go for the Zencoli capsulodesis, even though we know it stretches out over time.
Sorry, Prof, can I just ask?
Yeah.
The determining whether you do static or dynamic procedures based on whether they have positive reviews.
No. Yes, to a degree, absolutely. So if they can't get a bouvier, then you have to give them an intrinsic, and like you have to bring in a muscle to actually pull it up, because they can't use their own extrinsics to do the job. It's stretched out. But so that comes on to the next thing. What's going on here? Okay. So remember I said it's claw, it's grip, it's pinch. So the grip is the same thing. They've got very weak grip because they can't initiate flexion, and you need to bring in a muscle to act as an intrinsic to flex the MP joints so they can initiate flexion. So you can't do an anti-claw. Anti-claw just holds them in that position. It doesn't add a muscle to give them grip strength. So if they've got a negative bouvier sign, or if they need grip, so let's say you've got a right-hand dominant ulnar nerve deficient manual or semi-skilled labor, they need the grip strength, then you better give them an intrinsic muscle, which you can't do. Obviously, you can't make intrinsics, but you can give them a tendon transfer, and this is the one we use, the ECRL, extended into the extended through the lumbrical canal into the extensor mechanism. Traditionally, the lateral bands, but actually into the central slip. You can imagine if I've got a graft, it goes from the extensor mechanism, just proximal to the PRP joint, through the lumbrical canal, and I just have got it all forward. I pull on it, it's going to flex there and extend there. Okay, so sitting in the claw position, I go, that's what it's going to do. It's going to give me an intrinsic. It's going to powerfully extend and powerfully flex. And now my extrinsics can take over the job. So it actually adds grip strength. So that's the dynamic transfer, the ECRL, extended with multiple palmaris longus grafts. Okay. And you do that to give grip strength, pinch, grip, claw, grip, pinch. Claw, grip, pinch. You give it if you want grip, or if you have a negative Bouvier's test, which is rare, then you have to use this transfer. You can't just create a flexion form if they've got negative Bouvier's test. Okay, and then the last thing is pinch. Pinch is very complex. You think about how you pinch, there's many things happen when you pinch. Firstly, you've got to stop your index moving across, so you have to abduct your index finger. But your first dorsal and dorsal, which the abductor is gone. Secondly, you've got to adapt your thumb, and you've got to stop your thumb from hyperflexing the phromons or the gene side. Okay, so there are many ways to try and sort out to improve pinch, because that's actually the patient's biggest problem. And all said and done, forget about the claw, forget about the grip. The pinch is their problem. They have this horrible little phromons, and they can't pinch. Lateral key pinch is so important. Everything we do, grab things, pick up things, manipulate things. If you don't have good pinch, then you're in trouble. So there are many ways of doing it. You can see, as you can see, these are the different ways of dealing with it. You can increase the index abduction, and that's ERP to the first dorsal and dorsal. So that's our preferred procedure. You can go APL, extended with palmaris longus to the first dorsal. You can go EPB to the first dorsal. There are many different things you can do to basically improve your index abduction, or you can increase your thumb adduction. A lot of centers around the world do this operation. And they take the FDS and wind it across into the thumb. change the direction to pull the thumb close, or the ECRB around the back through the intermetacarpal space, then across to the thumb, the adductor. But those operations close the first web space, abstention. Pull the first web space, which is not a good thing for your hand to have a closed web space. Or you can just fuse the thumb, either the IP joint or the MP joint, because that then improves your stability of your thumb and increases the lever arm, so the FPL can work over a long lever arm. And that's our preferred procedure, the IP joint fusion. So if you combine those two, the IP joint fusion and the ERP to the first dorsal osseous, so we take the ERP, wind it around, put it into the first dorsal, so it acts as a resistor to thumb to index adduction, add some abduction, and you fuse the thumb IP joint to improve the lever arm of the FPL. Then you can substantially jack up pitch, and then the patients are happy. Okay, that's it. That's all the transfers you need to know. That's all the anatomy you need to know. That's all the compression syndromes you need to know for the ulnar nerve, and all the differential diagnoses for ulnar nerve problem. Any questions? Good. So can I just go stop share here? Eh?
Yeah.
Which mouse are we using? Are you guys any questions? We good?
Tom, I just had one question, maybe more formally related. When doing distal